Uh, so today's seminar is by Professor Purnendra Prasad. So Professor Purnendra Prasad is currently professor at the Department of Sociology, University of Hyderabad, and was the head of the department between 2017 and 20. He has previously been associated with the Center for Social Studies, CSS, Surat, and Tata Institute of Social Sciences, Mumbai. He teaches classical sociological theory, sociology of development, rural society and agrarian change, sociology of health, and urban sociology. In the area of agrarian studies, he focuses on the agrarian question to understand the changing agrarian relations and structure within capitalist development, and intends to pursue questions on class and class formations, caste and gender dynamics of agrarian society, farmer suicides, agrarian movements, to analyze what new ideas are discernible within the current rural-urban processes at play. In the area of political economy of health, Professor Prasad looks at the increasing inequalities in health systems in the context of the effects of globalization on India's development trajectory, and attempts to explain how state and market forces have progressively heightened the inequities in healthcare system and the process through which substantial burden of meeting healthcare needs fall on the individuals and households, impacting different classes, castes, gender, and other categories. He raises pertinent questions on commercialization of health, pharmaceuticalization, gendered body, right to health, universal access to health, ethical concerns, etc. Development in the context of globalization has also been Professor Prasad's larger area of research, including questions of development and displacement, disasters, decentralization, role of state, caste, class, and power, Indian cities, towns, and its urban transformations. Urban studies at large has also been Professor Prasad's area of interest, including the limitations of urban and mapping theories, focusing on non-metropolitan towns and cities, spatial and social exclusions rooted in the idea of the nation state. He has published extensively in regional, national, and international journals. Some of the recent ones include a co-edited volume, Equity and Access, Healthcare Studies in India, by Oxford University Press, 2018. Indian Cities and Current Forms of Capitalist Urbanization, a case of Amravati, Gurgaon, and Rajarhat in Sujata Patel edited Neoliberalism, Urbanization, and Aspirations in Contemporary India, Orient Black Swan, 2019. Unhealthy India, Is Privatization the Way Forward? Do We Care? India's Health System by K. Sujata Rao, Oxford University Press in MFC Bulletin, 2018. Silent Violence and Neo-Bondage in the Urban Informal Sector, a study of forced migrants in West Bengal, in Rajan Irudaya edited India Migration Report 2017. Pratlij. Revisiting Conceptual Debates in Agrarian Studies, Agrarian and Other Histories, Essays for Binoy Bhushan Chaudhuri, edited by Shubhra Chakraborty and Utsha Patnaik, Tulika Books 2017, the book review. Babu's Camilla, Amravati and the Emergent Capitalist Dynamics in New Andhra Pradesh, Economic and Political Weekly, 2017. Ethical Issues in the Recruitment of Healthy Volunteers, Study of a Clinical Research Organization in Hyderabad, Indian Journal of Medical Ethics, 2014, and many more. So welcome, Professor Prasad, once again. And you may begin now. You will be talking for about 45-50 minutes, and then we can open the session up for questions and comments.
Thank you so much, Devdatta and Satish, for inviting me to this series of lectures that CSSS is organizing. Let me also thank Professor Rosinka Chaudhary, the director, who also sent this invite and created an opportunity for me to share my ideas. Today that I'm talking about state and health markets in the times of a pandemic, this is a paper that I have actually finished writing, but it's an unpublished paper. So I also have my own interest in sharing these so that I think I get more critical feedback. And it's a more structured kind of a presentation that I would be making. That might test your patience in terms of time, but I hope there will be more discussion on this set of ideas that I want to propose. Okay. All right. Let me begin saying that COVID, of course, has provided an opportunity to peep into the, how social kind of order, is functioning, or how social processes actually are at play. So what I would do is I look at the state and health markets, particularly starting with the very background in which how COVID-19 actually is considered as some kind of an emergency, okay, or it was seen as some kind of an unexpected crisis. So let me begin there, and then I'll actually move on. Satish, the first slide. All right. Across the world, governments, including the Indian state, presented the COVID-19 situation as an unexpected crisis to be dealt with as an emergency. And yet, as Rob Wallace and others actually tried to explain, that these pandemics are neither unprecedented nor unexpected, given the deeper connection between capitalist agribusiness and etiology of epidemics, ranging from SARS to Ebola to COVID-19. COVID-19, of course, emphasis is mine. COVID-19, in fact, brought to the fore the fault lines across the world. Those countries with stronger public health systems, those countries with unequal access to resources, social inequality, democratic polity, state institutions, etc. While influenza, TB, malaria, HIV/AIDS continue to kill millions of people every year, COVID-19 seemed to have exacerbated the health inequalities and insecure features in India. Yeah, next slide. The government actually imposed lockdowns, containment, segregation, isolation, quarantine during the first wave. Satish, next slide. Yeah. However, millions of migrants and informal workers with no secure homeland of their own, either in urban India or rural India, went through widespread social suffering and died not due to virus, but because of the failure of the state in providing basic entitlements. In fact, Engels called this a social murder in explaining the then situation in England. And he argued that the then English ruling class and the state had created such horrendous working and living conditions for the workers without necessaries of life that they suffered not only ill health, but met early deaths. During the second wave, hospitals across the country, public and private in urban and rural areas, struggled to cope with the volume of COVID-19 patients, a large proportion of which required critical care, especially oxygen support. This was termed as the worst humanitarian and public health crisis in post-independent India. A year and a half into the pandemics, the Indian government revised its understanding of COVID-19, contradicting its own earlier claims of victory over it. One, the government now recognized that COVID-19 was not a one-time disaster, but rather an ongoing pandemic, which would continue to occur in waves with different intensity, symptoms, and mutations, with no certainty regarding the end. Second, it also recognized that there is a need to strengthen the public health infrastructure to contain COVID deaths. Of course, both these responses were stated in its 189-page affidavit to the Supreme Court in explaining these things. Basically, what I will do in this today's talk is to analyze the competing priorities of the state and the way it has been juggling with both so-called welfare agenda and privatization of health services. Okay, so the first part of my lecture, I will try and take you through the health situation, health status before COVID or before pandemic. Okay, how health systems actually to be understood. Next slide, please. So when you look at the state market nexus in healthcare, India's health system was already broken and fragmented prior to the pandemic, where over 4/5 of all healthcare expenditure was private. The current pandemic has only heightened the weaknesses in India's health system, trying to highlight the manpower shortages, low public health expenditure, which is little over 1% of GDP, highest out-of-pocket expenditure, regional, rural, urban disparities in health infrastructure, all contributing to high morbidity and mortality rates. While India's population grew by about 13.25% between 2011 and 2020. I'm sorry, I think it's written 2022. Between 2011 and 2020, the total public health expenditure of the central and state governments combined increased only by 0.39%. So that indicates, the priority that health sector has been actually receiving. Government health systems struggle on a continuous basis to cope with the burden, as almost 1 million children die of diarrhea, 4 million die of tuberculosis every year. And in fact, non-communicable diseases account for 7 out of the top 10 causes of deaths. And most of it are preventable. From 1947 to 1970s, if you look at the health policies, in some way, during the first phase, India adopted what is called as primary healthcare approach, which was guided by Sir John Bohr Committee recommendations. Next slide, Satish. So that's the first part, 47 to 70. It's a primary health approach. Second phase, 1970s to 80s, Indian state emphasized tertiary care over primary care, paving the way for more privatization of health services. The roadmap for healthcare and policies from then on emerged from these tensions and contradictions between hospital-based medicine on the one hand and primary healthcare on the other. This is reflected in the way Indian state was signatory to comprehensive primary healthcare approach, which was part of Alma Ata Declaration 1978. But it quickly moved towards selective, target-oriented, vertical national health programs, focusing on one disease at a time by early 80s. So commitment to comprehensive primary healthcare was part of the Alma Ata. But the way it moved because of the funding agencies, particularly in terms of Rockefeller and other agencies, which pushed Indian state towards, these vertical national health programs, one disease at a time. So the liberalization policies from 1990s marked a remarkable shift towards opening of health sector to more private investment and greater commercialization. While interestingly, in post 2000s, government intervention in healthcare, especially delivery of services, is restricted to financing of care, contracting services, negotiating reimbursement with private providers, rather than providing health services. So this is where I'm trying to indicate the huge kind of shifts during different kind of phases in India. Okay. Now, when we move, what are the implications of these kind of shifts? Okay. Now I come to the health industry and health markets. Basically, health industry and health markets comprise in India hospitals, health insurance companies, pharmaceutical companies, medical device companies, diagnostics, clinical trials, medical education, and also medical tourism, of which hospital sector alone accounts for about 70% of the total market. significant changes, Satish, next slide. Significant changes in the health sector have taken place from late 1990s, where hospitals were set up as private and public limited companies. The first private equity investment in Indian healthcare was in 1999 by UK-based global asset management company, Schroeder Ventures, which invested in Indraprastha Medical Corporation Limited. This was followed by several foreign-based equity investors, starting with IHH Berard Malaysia, TPG Group, Carlyle Group US, Advent International, Government of Singapore Investment Corporation, Davita USA, and a lot of companies from Germany, from Japan, from Dubai. Okay, so with several hospital projects funded by International Finance Corporation of the World Bank Group, corporatization of healthcare got accelerated. The story of one of the largest corporate hospital chains, India Fortis, indicates that profits from pharmaceutical sector have been used to expand into hospital sector. In fact, the big corporate hospital chains such as Apollo, Narayana, Fortis, besides running their own hospitals, also now involved in managing other hospitals. In addition to all this, state actually not only facilitated the private capital into health sector, but it also tried to channelize almost 30% of the patient supply to corporate hospitals through CGHS schemes. And this has actually, fueled the growth in the private and the corporate hospitals and corporatization of healthcare. So by 2000s, Indian state allowed 100% foreign direct investment route in hospital sector, pharmaceuticals, that greenfield projects, and manufacture of medical devices, and third-party administrators by the Insurance Regulatory Authority. So from mid-2000 onwards, the health insurance market has grown phenomenally under Union government's RSBY, Rashtriya Swasthya Bima Yojana, Pradhan Mantri Jan Arogya Yojana, and several similar state schemes. In fact, National Health Authority was created under Niti Aayog in 2019 with the explicit purpose of managing PMJAY, these insurance schemes, and catalyze market-oriented reforms across health sector. It is estimated that health insurance today contributes 20% to non-life insurance business, making it the second largest portfolio. So healthcare based on government-funded health insurance schemes occupied center stage in policy making and also as panacea for all the health-related kind of issues. The moment there is COVID, several state governments actually started getting demand that this procedure and that procedure need to be included in the health insurance schemes, and state needs to pay for that. So in a nutshell, the concept of medical industrial complex, which was proposed by Relman, it captures how escalation of corporate medical power in every domain of healthcare industry has taken place in India from post-90s and probably more intensely in the post-2000. Okay. Now, does it mean that state policies and state kind of, imagination has been linear and straitjacketed in terms of healthcare? I argue that Indian state has been aggressively pursuing hegemonic, dominant, market-oriented policies on the one hand, at the same time, articulating community health discourses due to the pressure from below. Next slide, Satish. State health policy can be characterized as double movement using Karl Polanyi's framework. In Polanyi's view, when the state attempts to create a market-oriented society from the above, it compels a movement from below to moderate its severely dislocating effects. That is how the state has been straddling between market expansion and counter movement to restrict market expansion. For Polanyi, the creation of a market economy entails a dual shift in state policy, a combination of aggressive intervention to extend the play of market forces, at the same time expand these social protection policies to relieve the hardships of the displaced people and the market forces. In fact, as a case in point, I bring in, from 1970s onwards, how civil society groups actually have been, very effectively bringing in pressure from below for state to, affect certain kind of changes that are more, pro people. Okay. I'm just giving some examples here. For instance, comprehensive rural health project Jamkhed in rural Maharashtra, established in 1970, it championed comprehensive community health model with village health workers belonging to lower caste and local women playing a very instrumental role in providing health services. And that was one model. Similarly, Medico Friends Circle, established in 1976, was a support network for groups of doctors influenced by the ideas of social justice, equitable access to healthcare for all communities, castes, and genders. It challenged the state's attempt to turn public health into a purely technocratic realm of expertise and utilitarian kind of calculations. Even during the era of intense privatization of health sector, alternative ideas and people's health movements did emerge. To mention a few, Mandwa project that NH Antia and others actually experimented for 6 years, which provided an alternative strategy for healthcare and highlighted resistance in terms of rural power structures and medical professionals. Similarly, Sehat, Center for Inquiry into Health and Allied Themes, another organization established in 1991, Jan Swasthya Abhiyan, established in 2001, have raised voice of dissent, advocated right to health, decentralization of health services, women's health rights, gender equity, access to medicines, etc. So these movements from below, that what Polanyi is trying to talk about, the counter effects of the market forces, can be seen how it reflected in the policies between 2004 and 2014, even during the peak of the neoliberal kind of a phase. One could see, given the coalition politics with the coalition politics in India, UPA government, and with people's health movements, Indian state launched what is called as National Rural Health Mission in 2005, along with, of course, MGNREGA in 2006. So this NRHM was intended to actualize comprehensive primary healthcare and provide accessible, affordable, quality healthcare to rural population, especially vulnerable groups. Subsequently, high-level expert group was constituted in 2011, which recommended universal health coverage to achieve health for all. Similarly, one could see Rajasthan government experimented successfully with a healthcare model for providing free diagnostics and medicines during 2010 to 2014 under various schemes. And there are several studies that show that during this phase, the proportion of people seeking healthcare from public health institutions in Rajasthan increased significantly. So despite state pursuing aggressive neoliberal policies, it did launch NRHM, constituted high-level expert group for universal health coverage, experimented with free medicines and diagnostics in post-2000s in Rajasthan, which all indicate a counter narrative and movement from below. In fact, next slide, Satish. In fact, several progressive legislations and regulatory mechanisms were also brought because of the purely pressure from these civil society organizations. Partly, of course, it is a political expediency. Partly, this is also an imperative for the state to appear pro-welfare while not really operationalizing it. For instance, Clinical Establishment Regulation and Registration and Regulation Act, which defines how much to be charged for each of the surgeries, Okay, so there is a clear kind of a legislation which regulates that private hospitals and corporate hospitals cannot charge, under the sun. There is a regulatory kind of a mechanism. Okay, but in reality, while this intervention is very critical, but corporate hospitals hardly follow any of these regulations either before the pandemic or during the pandemic. This act was in fact passed in the year 2010 and was applicable to 11 states across India, but it's not implemented due to a major delay, a technical kind of a delay that is intentional, in notifying central minimum standards and failure to develop central framework for regulation of the rates, how much to be charged. Okay, so Sunil Nandaraj and others actually point out that public and private interests alike have been complicit in keeping the provision of this kind of Clinical Establishment Act unimplemented. So similarly, you have National Commission for Allied Healthcare Professional Act 2021. Okay, and I will not go into the details. You have notified medical devices which were all brought under the drugs and cosmetics rules of 1945 in order to control the prices of the medical devices. Okay, including the cardiac stents and other things, which the prices actually have fallen only because of these legislations that have been brought into the drugs and cosmetic rules. And studies have shown that share of these medical devices based diagnosis in households out-of-pocket expenditure has in fact increased from 2.2% in 93-94 to 7.6% in 2011 to 12 because of the lack of implementation of some of these regulations. Medical devices industry, in fact, played a very important role in transforming the hospitals from small-scale enterprises to the status of a large-scale industry kind of things. Similarly, you have this list of price controls on drugs and pharmaceuticals by the state. Okay, particularly the National List of Essential Medicines 2015, where they tried to introduce certain kind of medicines into the list so that the prices do not go up. Okay, so this is where I'm trying to demonstrate certain kind of a counter movement in bringing in certain progressive and pro-people kind of legislative things, but operationally they did not actually have much impact. Next slide, Satish. The question of how the Indian state can be characterized has been a long-standing concern for political economists. How do we understand the nature of state? Rudolph and Rudolph dubbed India as weak, strong state, where demand politics and command politics remained in unsteady equilibrium. The weak, strong state, according to John Race, has another essential ambiguity. While the state can appear inflated and ubiquitous, it often exhibits scant presence in the lives of marginalized social groups, people living in remote rural areas, or those operating in the vast informal economy. State has been analyzed as a market activist in relation to capital accumulation, Prabhat Patnaik, an aggressive market player similar to a corporate kind of an entity that Kaushik Sundar Rajan, and increasingly in the post 2000, state is actually acting as an aggressive market player. The policy is directed only to govern the private enterprises, etc. So as Gramsci pointed out, market and the state were always mutually implicated. Gramsci comments on the state and state power, saying that the economy in its inclusive sense comprises an accumulation regime plus mode of regulation, and that accumulation occurs through self-valorization of capital in and through regulation. Gramsci emphasized that the state was always present in the regularization of these capital relations. State has an active role in the organization of economic relations, class domination, in securing the long-run interests of the bourgeoisie in facilitating concessions to subordinate classes, and at the same time securing an active consent of the governed and effectuating their disorganization. So as big, now what is the story that we are talking before pandemic? what Christopher Jofferlot and Atul Kohli and others have said, big businesses actually have gradually strengthened their alliance with the state, and that story actually is much more clearly reflected in the health sector. Now, I argue that how do we actually analyze these alliance of big business with the state? Okay, I see four major kind of trends that have emerged from this growing state market nexus in healthcare. Okay, based on the available studies, I actually point out these four major trends. Next slide, Satish. One, the first slide, in 1980s and 90s, the upper caste and intermediary caste who invested in hospitals, medical colleges, pharmaceuticals, and diagnostics are today increasingly taken over by the multinational companies. This is evident with top hospitals in every metro city in India has effectively been taken over, or their share actually has been increased by the foreign capital. It resulted in, of course, the cost of treatment getting hiked from 5% every year, now 20 to 25%. Several studies pointed out that these hospitals have ensured their profits by giving doctors targets to be fulfilled through available patient loads or by increasing patient numbers. Apart from giving targets to consultant doctors, business models are moving patients from general practitioners and small hospitals into these multi-speciality and corporate hospitals. So that's the first kind of a trend, how top tertiary hospitals have been taken over by foreign capital. Okay. In fact, I give examples in terms of Hyderabad. I list out all the corporate hospitals and the share of the foreign capital today and how the prices and other things have increased, etc. Second major trend is that you have a huge kind of middle segment. Okay, middle segment in the health sector comprising of below 40 beds hospitals, one specialty clinics, nursing homes, and also in terms of some of these charity hospitals. About 20% of these middle segment have been closed down during the last 2 years. Several charity hospitals in Mumbai, for example, have already been taken over and tied up with for-profit hospitals or hospital management companies for operations and management of hospital services. In April 2019, Jaslok Hospital, one of the oldest trust hospitals in Mumbai, entered into profit-sharing agreement with IHH Malaysia, which also operates the Gleneagles Global Hospital in Bombay. So that's the second trend, what happened to the middle segment and how cost actually has escalated, how charity hospitals also have been taken over. Third one, the alliance of the big business and state, it enabled footloose corporate hospital chains, which are functioning with high value production and flexible labor markets. They are able to recruit paramedical and nursing staff on contract with lower wages and poor working conditions. Professionalization of nursing in India was always intertwined with caste hierarchy and stigma associated with menial manual labor structured by class, caste, and sexuality, which is evident in the nursing labor market. For instance, Bist and Meenan point out that a vast array of casual contract, temporary, part-time health care workers fill the lowermost ranks of the health services. About 1 million ASHA workers in government sector are not even treated as staff. They occupy a liminal position in the state who belong to scheduled caste and OBCs, who are paid poor wages with limited welfare protections. So thus, this conjugated oppression, which divides the frontline health workers, and this is how capital gets serviced and subsidized by underpaid care work done both by public and private hospital kind of a lower working workers and the staff. So this is the third, and the last point is about the corruption. Corruption and unethical practices actually pervades the health regulatory councils, the Medical Council of India, now replaced as National Medical Commission, and its sister organizations, Nursing and Dental Council, etc. So government-funded insurance schemes from 2007 onwards became a major driver for unscrupulous practices in the largely unregulated private health sector in India. Even during COVID-19, doctors actually are forced to order unnecessary and expensive tests, demanding huge down payments before admission into private and corporate hospitals. So this is the scenario that I was trying to explain as part of first part of my talk. In the second part, what I will take you is to healthcare during the pandemic period. While public health sector, next slide, Satish. While public health sector with 27% inpatient facilities was overcrowded and crumbled during COVID-19, the private and corporate sector with 73% inpatient facilities is estimated to have handled less than 10% of the patient pool, the COVID cases. Realizing the limited health infrastructure, a few state governments during the COVID period ordered private hospitals to reserve 75% of their beds for COVID patients. They also imposed a rate capping of treatment and hospital expenses to be paid for under different public schemes. Okay. However, a survey conducted in September 2021 from 2,570 families who have undergone treatment for COVID-19 in various hospitals across Maharashtra indicated that 75% of the COVID patients experienced overcharging compared to the official rates. On average, each patient in the study was overcharged by about 1,55,934. So the serious issue of women who have lost their husbands to COVID, in fact, faced the double burden: death of main breadwinner, loss of livelihood, and huge debt due to massive hospitalization expenses. So the average medical expenditure for COVID patients treated in government hospitals was 17,000, while in case of private hospitals, it was 5 times more, about 90,000 rupees on an average, based on Corona Ekal Mahila Punarnivas Samiti and Jan Arogya Yojana studies that I'm trying to indicate. Not only this, in fact, during COVID, state announced new schemes and programs pushing the middle and lower classes to depend on private healthcare for their daily needs. For instance, new insurance schemes such as Corona Rakshak and Corona Kavach were offered with directions from IRDAI in June 2020. Despite this insurance coverage that state actually claims that it is to cover the COVID patients, it's reported that around 43.5% of the medical cost was paid by the individuals from their own pockets. Similarly, a study on the efficacy of PMJAY in Andhra Pradesh, Karnataka, Kerala, and Tamil Nadu found that out of 18 lakh people hospitalized for COVID, around 85% of them have paid for hospitalization from their personal savings and borrowings. Okay. So you have like that, several schemes have actually come in, okay, but people had to actually pay from their pockets. Thus, for COVID affected people, out-of-pocket expenditure was highest. While health insurance companies' profits grew substantially during COVID time, when the larger economy was declining and in the dumps. But this is how the insurance schemes facilitated further consolidation of capital during the COVID period. And now coming to the very critical kind of a dimension of vaccines. Indian state relied on its attempt to regulate other actors and outsource critical capacities, especially vaccines. Next slide, Satish. This is quite evident with the way ICMR, a key scientific government body, collaborated with a private vaccine manufacturer called the Bharat Biotech for the production of Covaxin, and not with any of the public sector units. While 7 public sector vaccine manufacturers have the infrastructure and capability to make over 500 million doses of COVID vaccines per year, Indian state did not even make an effort to actually approach the PSUs. However, research studies also implicate how state and its vaccine policies are not just about, only during the pandemics, but since 2008 in India, this is the turning point when Bill and Melinda Gates Foundation was allowed to engineer a shift in research and manufacture of essential technologies such as vaccines from public sector to private biotech labs and factories. So from 2008, there has been actually a huge kind of a shift in government kind of policies, particularly the biotech labs, how private biotech labs actually have taken over the vaccine production, etc. And COVID actually provided a better opportunity. So the two private vaccine companies, Bharat Biotech and Serum Institute of India, okay, were able to make COVID-19 vaccines only because of considerable government support and resources. Bharat Biotech in India and Serum Institute's, Covishield in UK, a large set of public resources were actually, spent. With the start of the second wave and a rapidly rising number of deaths, government further facilitated these two vaccine companies to realize their profits by agreeing to provide 4,500 crore grant to increase their manufacturing capacity. However, Indian government, while permitting these two companies to set their own differential prices, it also bought vaccines at a price determined by the suppliers. This goes on to show two things. One, the government's pricing policy has provided a huge booster to make a quantum leap in profits for pharma companies producing vaccines. Second, state subsidized research and development with public money only to go on and create an oligopolistic market for vaccines dominated by a very small number of pharma companies on which the state then depends. Several scholars explained these trends in terms of neoliberal regulatory state, which emerged as part of the wider shift from government to governance, thus diminishing the ability of the state to address basic healthcare. The neoliberal regulatory state involves shifting the implementation and compliance burden away from state agencies towards the entities being regulated. Where governments once directly supplied public goods and services, now client-operator contractualism prevails, with public bodies becoming negotiators rather than providers. Okay. So this is where one could see how main beneficiaries of the rise of this regulatory state have been large-scale businesses for whom it has opened a new avenue for capital accumulation. This is quite evident with the way, next slide, Satish. This is quite evident with the way health sector has emerged as one of the largest business in India, with a market size of $194 billion in 2020 and is projected to reach $372 billion by 2022. This is India Brand Equity Foundation report. And it also received a large foreign direct investment flows from $50 billion in 2019-20, which was just $2.5 billion in 2000 and 2001. Okay, so in a sense, in March 2021, the total number of Indian billionaires rose from 102 to 140 despite pandemic, and the 2 of the 10 richest Indians got their wealth from health sector. Cyrus Poonawalla of Serum Institute became sixth richest person in India, and his wealth increased by 74% with the supply of just COVID-19 vaccines. And this is the report by IIFL Wealth Hurun India Rich List 2021. 8 of the top 10 richest individuals from Telangana and Andhra Pradesh are pharma industrialists, and their cumulative wealth increased by 54% in the last 1 year. So as Susan Sell points out, not everyone is looking forward to the end of the pandemic in the same way. It really depends on where you stand in the global distribution of health, wealth, and power, with welfare system, public health provisions, disease monitoring methods, public scientific research, vaccinations. every bit of life, public life being subjected to privatization and financialization. So the pandemic has exposed further fault lines, indicating how state not only promoted the interests of private capital, but also it increased its authority over civil society, especially the laboring classes, and it widened the gap in terms of access to healthcare for lower caste women and vulnerable groups. I have noted three major trends in terms of pandemic experience. First, the COVID-19 exception was used by the state to bypass statutorily constituted National Disaster Response Fund under the Disaster Management Act 2005 to bring PM CARES Fund, that is Prime Minister Citizens Assistance and Relief in Emergency. PM CARE, a public charitable trust which is neither answerable nor accountable to the public. Similarly, it passed three new labor codes where government minimizes its regulatory role and reduces its responsibility for oversight. And it also passed and of course withdrawn three farm laws, accelerating the role of big capital in agriculture, commodification of land and labor for the urban capital. Okay. So as Agamben pointed out, there is a danger of exceptionalism becoming a rule rather than an exception. Second, during the first wave of COVID-19, government declared that there is no data on migrants. While in the second wave, it claimed there are no deaths reported due to lack of oxygen, despite intense suffering and millions of deaths. So government denied any knowledge about number of frontline health workers who lost their lives, number of deaths caused by manual scavenging, no information on the condition of labor during the pandemic. Thus, state abrogated its responsibility and accountability to the public, where we can see Foucault's notion of governmentality that helps us understand how and why the state continues to play such a central and constitutive role. Only because its reference to some central entity, can this governmental practice exist and appear as more legitimate. And the third kind of a trend one could see during the pandemic, upper and middle classes during the COVID-19 realized individual vulnerability to factors outside one's perceived control, and that one's health is tied closely to others as much and need strong measures by the state and its institutions. See, till then, when public health institutions were in disarray, middle classes actually did not have any big thing. But suddenly, during COVID, the middle classes actually felt that access to private hospital, a health insurance, or best of the specialist doctors did not count because they also needed to go through vulnerability and fear like the lower classes. The state was expected to step in, but it wasn't there. The promise of post-liberalization India was that it would insulate the middle classes from the plight of the poor who can't access healthcare on a daily basis. However, the lower castes and classes always knew this, that their health is not within their control, that the choice is between drinking no water at all and drinking contaminated water. But their lives have not mattered enough to generate the kind of discussion on state interventions that COVID-19 has raised. This situation is exacerbated by structural inequalities of caste, class, gender, geography, and community in India that translate into health inequalities and are amplified by the state of the health system. So this is where I analyze the second part in terms of the pandemic. But I think Devdatta seemed to be, alerting me to the time. If I have exceeded already my time, maybe
No, not at all, not at all.
Okay.
Professor Prasad, you can have a little bit of more time. If
Another 5 minutes.
Yeah, sure.
Yeah.
Sure.
Yeah. So I think I have analyzed till now what I did before pandemic, what was the kind of situation, what are the new trends that emerged with the state alliance with the big businesses, and during the pandemic, how and what. And now what I'm trying to do is a quest for an alternative. What's the way forward? Is there a kind of a counter movement possible? Okay. Several surveys and reports indicated that pandemic resulted in huge loss of jobs, severe decline in earnings, sudden increase in poverty, increased reliance on petty jobs in informal sector, surge in medical debts, borrowing and selling of assets. In fact, analysis by the Pew Research Center estimated that around 75 million people fell into poverty, people who live below $2 or less daily, and that India accounts for nearly 60% of the global increase in poverty in 2020. World Bank research data published in the British Medical Journal shows that economic decline accompanying COVID-19 may have caused 1 lakh excess infant deaths in India. If pandemic has exacerbated the inequalities and inaccessibility to healthcare, whether and how personal and collective insecurities of the subalterns associated with contemporary capitalism will give way to a counter movement or counter discourse is what is another central kind of a question that I have in my talk today. So I'm raising this question saying that can post-COVID rip open the possibilities of other world? If so, what alternative pathways does it open up? A glimpse of historical events indicates that crises have always shaped the history of several nations. For instance, the global flu epidemic of 1918 helped create national health services in many European countries. The twin crises of Great Depression and the Second World War set the stage for the modern welfare state. At the end of the Second World War, as a battered Britain scrambled to regain its economy and heal the trauma for its citizens, Sir William Beveridge instituted a public health system that led to the establishment of national health system that's called NHS, where high quality medical services are provided to all citizens by the state. Of course, one is not romanticizing the British NHS, as one needs to take the ideological context when it was brought in the late 1940s. With Lansley reforms, 10 years back, huge structural changes have taken place even within NHS. Okay, a lot of critics actually point out that British NHS is also increasingly getting oriented around private providers today, private insurers and market structures for allocating resources. So that their worry is that I think it's not like earlier, and there is also certain seepage and certain kind of creeping in of the private and market forces there. This is where I think Arundhati Roy points out that historically pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It's a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks, and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly with little luggage, ready to imagine another world and be ready to fight for it. The quote close. So given the situation, what were the lessons learned from the pandemic and how do we actually understand the state's response to it? COVID-19, of course, provided concrete experiences and the need to strengthen the government healthcare. Successful integration of local government into healthcare system, for instance, Kutumbashree, decentralized government healthcare services in Kerala have translated into a more effective overreach, timely testing, early case detection, and more rational treatment for COVID patients, which together reduced fatality rates. Similarly, Tamil Nadu's efficient healthcare model lies in the efficiency kind of a gain it resulted from separate and well-organized approaches to public health and medical care. There is a separate cadre of public health in Tamil Nadu, which is actually different from the medical care. So several studies indicated that effective public health services reduce the need to expensive curative services, and it also results in better value for public expenditure on health, etc. In fact, recent studies, this is based on NSSO 71st round and for 2017-18. Okay, a couple of scholars from IIT Chennai, they pointed out that there is significant increase in utilization, especially by the poorer sections of the society, of public facilities for both outpatient and inpatient services. As a result, there is a consequent fall in the overall financial burden on patients who otherwise would have used only private health services. So by strengthening the public health system, what has actually it resulted in, okay, so if government health expenditure and access to government provision of healthcare increases, there could be a significant shift of patients from private providers to public facilities and dramatic fall in out-of-pocket expenditure. Can Kerala, Tamil Nadu, Rajasthan's free diagnostics and medicines models be emulated at national scale? While the healthcare model of these three states also have certain distortions with increased preference for hospital-based tertiary care rather than primary healthcare in the last 2 decades, which is also evident during pandemic. But there are several components and elements that stand out for scaling up and reimagining national health services. Pushing aside these experiences and evidences gained during the pandemic, Indian state is inclined more towards strengthening its capacities through outsourcing and dependency on private companies. This can be seen in terms of two trends. One, Niti Aayog, the government think tank, sees COVID-19 as a prime business opportunity to be exploited, stating that in the hospital segment, the expansion of private players to tier 2 and tier 3 locations beyond metropolitan cities offers an attractive investment opportunity. So this is what is the recommendation of Niti Aayog. And now Niti Aayog is suggesting that running district hospitals on public-private partnership model, and all states should allot part of the state-run hospital space to a private players for a 30-year lease, okay, with 50 or 100 beds. Niti Aayog justifies saying that by involving private players for this is only to reduce the burden of non-communicable diseases, etc. All right, I think I'll skip a lot of these things where how state is actually, instead of moving, based on the experiences, how there is aggressive kind of a facilitation of corporate capital, even after the COVID kind of situation. So this, let me now conclude. This brings to the fore a central question. How should healthcare be reorganized in India, and what experiences do we learn from the pandemic? Two contradictory discourses are at play in the current moment. One, state is accelerating the interests of capital by strengthening the health markets in myriad ways, using the pandemic as an opportunity. Second, counter-hegemonic health discourses are also getting articulated, but the voices of the margins are not so effective. In strategizing this, Gramsci points out that head-on assault on the state and the hegemonic elites that hold it may not work. He distinguished between war of maneuver, which is a full-blown attack on the institutions of hegemony, trying to seize the state on the one hand, and war of position, which is a long-range contestation for ideological hegemony, which is a gradual process taking place on many fronts. A war of maneuver, which is a long-range contestation, may succeed in overthrowing the current hegemony, but if its impact is to last and a new hegemony is to be forged, it requires the organization of widespread consent, achievable through a prolonged war of position within civil society. Indeed, the challenge lies in building a consent among different civil society organizations whose visions are very diverse. And the experience of pandemic has made also two things clear. One, role of state and its intervention is very critical for any improvement in the health status and well-being of subaltern classes. It was evident that public sector could mobilize vast resources in times of crisis. Therefore, state should focus more on provisioning rather than restrict its role to financializing, contractualizing services, negotiating reimbursement, etc. Second, with corporatization of healthcare and insurance-led healthcare models, increased financialization of healthcare, it has only spiraled out-of-pocket expenditure for even lower and middle classes beyond their limits. Therefore, civil society organizations should actually build broad-based democratic movement, making healthcare a political agenda. The question here is whether and how a coalition of caste, class, and gender from the subaltern classes gets constituted to take the war of position to engage ideological as well as political struggle to advance this counter-hegemonic movement in India. Thank you. Thank you so much for your patience. I think I took little longer time than probably you allowed me.
Not at all, not at all. Thank you so much, Professor Prasad, for that very, very neat, comprehensive, and should I say, a very scary picture of where the healthcare system of India stands. And like you said, COVID, the whole pandemic phase showed us, pointed to us how exactly the entire system is going wrong. We will now open this session up for questions, comments, and in that I'll just begin, as in it's just